Hello and good evening, everyone, and welcome to our webinar this evening, which is the third event in a four-part series exploring the topic of adapting to a neurodiversity paradigm, affirmative paradigm in child and adolescent services, St. John of God's, CAMHS and primary care. My name is Claire O'Neill and I am the Head of Training with Thriving Autistic and a Deputy Principal deeply committed to inclusive practices, and I'll be your chair tonight. This event is brought to you as part of a joint initiative by the Children's Clinic, the Adult Autism Practice, Thriving Autistic, Child Diversity, HSC and St. John of God's Community Services Initiative in collaboration with the Autism Special Interest Group of the Psychological Society of Ireland. Throughout, you can submit your questions and comments through the question and answer button on the bottom of the screen. Please do try and get your questions in throughout the presentation, as we may not have time in the question and answer section to answer new questions. At the end of the presentation, we will hold a live panel discussion with our contributors, and we will try to get to as many of your questions as possible. We won't be able to respond to anyone who raised their hands throughout the webinar, so please make sure that you use the question and answer function instead. At any stage, please feel free to take movement breaks or get drinks as you need them. This is a webinar, so nobody can hear or see you. If you are tweeting tonight, please use the hashtag Neuro-Affirmative Webinars and tag the PSI Autism SIG. If you require CPD points from the PSI, please email autism@psychologicalsociety.ie after the event. We're going to do our very best to keep to time, and hopefully everything will run as smoothly as possible. I'd just like to remind you not to share your attendee link with anyone else. The event is completely booked out, and sharing your link means that somebody who's registered for the event will miss out on their place. We are recording this event, and the recording will be made available publicly online, and we are also streaming to Facebook. So please pre-register at the PSI for the final of the webinars in this series, which will take place on Wednesday, the 3rd of November at 8 p.m, where we will explore adapting to a neurodiversity affirmative paradigm in child and adolescent services, and in how to apply this to autism diagnostic assessments and report writing. There will also be a workshop for psychologists on neurodiversity affirmative adult autism assessments at this year's PSI annual conference on Wednesday, the 10th of November. And I'm very excited to say that coming in 2022, there will be a release of a book called the Neurodiversity Affirmative Adult Autism Assessment Handbook, which is being published by Jessica Kingsley Publishers. Now, without further delay, I am delighted to launch proceedings. Tonight, we will first hear from Jessica K. Doyle, who will give a foreword to tonight's events. Then we will hear from the St. John of God's CAMHS team about neurodiversity affirmative changes they've made in their practice. Then we will hear from Juliana from the HSC Primary Care about her project. And finally, this will be followed by a half-an-hour question and answer session. I'm now going to pass you over to Jessica Kay for the foreword tonight. Jessica is autistic, works as an assistant psychologist at the Adult Autism Practice, is a sensory processing project officer at TCD Sense, an independent researcher and a director of Thriving Autistic. Thank you very much, everyone.
Hello. I'm going to do the foreword. By now, we should all be aware of the devastating effects of persisting with harmful stereotypes. Supports grounded in medical model assumptions and engaging in practice that encourages masking autistic features. How it creates barriers for authentic development, leading to isolation, loneliness, disconnection, threats to mental health, and without adequate support, far too early mortality. There is the issue of unequal resources offered to autistic individuals struggling with their mental health, which often insist on putting the person first, but does not recognize the person as autistic. or ignores the need for mental health support because the person is autistic. Tonight, we will hear from two teams who are paving the way to changing these practices and providing strong supports for autistic children and adolescents that acknowledges, accepts, and values the autistic experience. These teams are starting by adapting their own services to be neurodiversity-affirmative. We need much more, though. If everyone could make little changes, then we could all act as cascading pebbles moving the river to flow. It is much more than simple language change, though. We need to work to build strong foundations behind these changes to fully shift to a neurodiversity paradigm. Through our actions, our work ethos, challenging old assumptions we have, through our communication, how we think about, talk about, and support autistic individuals, and how we make space, share, and design this world for all neurotypes. We need to truly recognize autism as a different yet entirely valid neurotype. Regardless of co-occurring conditions, need for support, diverse communication, learning, and expression styles, all autistic people have the right to dignity, autonomy, privacy, respect, mental and physical well-being, inclusion, freedom, and when needed, the respectful support from a person they trust to fully access all their rights. Language changes cannot sit above a hollow surface. It's not as simple as using feel-good neuro-affirmative language and calling it a day. Behind these changes cannot hide a hollow surface. It can start with language, but don't stop there. Keep walking. Work with others to learn more about ways to change and adapt and understand the neurodiversity paradigm. Work with the autistic community, collaborate, and together we can connect and build strong foundations. As Vincent van Gogh said, great things are done by a series of small things brought together. And as Helen Keller said, alone we can do so little, together we can do so much. Now that's enough for me. I will now pass you back to Claire to introduce tonight's presentations.
Much, Jessica, for that. I'm now delighted to introduce the St. John of God's CAMHS team. Dr. Sonia Morris is a clinical psychologist with CAMHS. Sonia has worked in varying capacities and across various services with autistic people for the last 15 years. Paula Monaghan is an occupational therapist working with CAMHS. Before training as an occupational therapist, Paula worked for 5 years as a support worker in a service for autistic adults. And Caroline McCrory, who unfortunately could not make it tonight, is a senior speech and language therapist working with CAMHS and has worked in primary care, speech and language therapy, and also in early intervention after graduating from Trinity in 2016.
Struggle to find the unmute button there for a second. Just to introduce ourselves before we start so that you know who is who. My name is Sonia.
Hi, and I'm Paula. So just thank you so much for having us here this evening and allowing us to tell, the very, very beginnings of our neuro-affirmative journey and changes in a CAMHS service. So yeah, thank you for organising and letting us be part of it. Great. So yeah, myself and Sonia work in CAMHS, which for those who are aware, it's the Child and Adolescent Mental Health Service. So CAMHS is a free specialist service for those children and young people under the age of 18 who are experiencing moderate to severe mental health difficulties and need treatment from a team of mental health professionals. So some of the difficulties we see in CAMHS are moderate to severe anxiety disorders, depression, eating disorders, thoughts of suicide or self-harm, psychosis, and moderate to severe attention deficit hyperactivity disorder. And ADHD falls within the remit of CAMHS because it's often treated by medication that's prescribed by a psychiatrist. So Sonia and I work on Team A, which is based out of that lovely clinic in the picture in Rathgar. So there's 3 teams based out of Rathgar. And each CAMHS team is multidisciplinary. So it is there's a consultant psychiatrist, psychiatric registrars, psychologists, nurses, occupational therapy, speech and language therapy, social workers, and social care workers that form our teams.
Okay, so nowhere in that description does it actually say autism. And somebody was recently reading the operational guidance for CAMHS and sent me a voice message and was asking, it actually says there that you don't work with autistic people, and what is the story with CAMHS? And it was a very good point. So this slide is just to illustrate where we as a CAMHS are coming from when we're talking about our work with the autistic population. So this table that I'm presenting here is from a recent systematic review of quite a number of papers that were reviewed and recorded with the stats, so 96 papers. Unfortunately, I don't have stats for Ireland about co-occurrence rates specifically, or indeed specifically for our team or our service, but these will do good enough. And I suppose it's just to illustrate, I suppose, what our work is within a CAMHS setting. So unfortunately, the co-occurrence rate of mental health concerns with autism is quite high. Jessica mentioned in her forward there that quite rightly, you know, if autism goes unrecognized and unsupported, particularly in the early years, it can lead to mental health concerns. And we certainly see that within a CAMHS setting. So Paula mentioned that ADHD currently finds its home within a CAMHS, and that is another neurodivergence. And this paper suggests that the co-occurrence rate with autism is as high as 28% if you take the average across those 96 papers. So like we have half of the caseload on team A is ADHD. So if you take that co-occurrence rate, we already have a lot of autistic people that are attending our service. Then we lead down to the mental health concerns, and unsurprisingly, given the environment and how it's set up at the moment, it being non-conducive to being autistic, anxiety disorders are quite high in the autistic population, as high as 20% is estimated by this paper. And I've put the link, by the way, the paper that we're quoting from just there down below. It was the most recent one I could find. So if anybody wants to read the paper in full, that information is there. Depressive disorders then 11%, obsessive compulsive disorders 9%, bipolar disorders 5%, and schizophrenia spectrum disorders 4%. So you can see quite clearly from that table that a lot of autistic people are coming to our service with moderate severe mental health concerns and or ADHD. So when we're talking about the changes that we've made on our team, it is from that perspective.
So why change? So I suppose since the label of autism has been about, it has been viewed in the medical terms. And as Sonia mentioned, we are working alongside young autistic people who are also experiencing moderate to severe mental health difficulties. And we recognize that there are different ways to look and think about autism that might better support the young people that we see. So we became really aware of the emerging neurodiversity movement that was growing online, particularly on social media, and from the young people that we were working with in the clinic. We started, by really looking outwards and trying to learn as much as we could from the community itself. So it really started with listening and learning from those young people who were attending our service about their experiences. And this led to the creation of a new group within the service where young people were able to explore their autistic identity and what it means to them. And we will talk a little bit more about that group as the presentation goes on.
Just to give a brief overview, I suppose, of some of the changes that we're going to have a chat about today, and to emphasize, as has been emphasized in all the previous webinars so far, that this is, we're in no ways perfect on our team. And we still have a lot of learning to do and a lot of change to do. And as Jessica also mentioned in her forward, it starts, with a different way of language, of using language, and then it branches out from there. And we are very much at the start of our journey as a CAMHS team. But some of the things that we've done have been really impactful and really helpful. And I suppose we see our role here tonight, if there are other CAMHS professionals here and other CAMHS clinicians, as showing that there is a different way to look at autism, that there is a different way of working with the autistic people that attend our service, and that even small changes can have a big impact. and can be adapted within that CAMHS way of working, that CAMHS model. So the ones that we've decided to focus on today are the ones that I suppose have made that biggest change on our team and the biggest change to our service. So we're going to talk a little bit about collaboration and collaborative projects that we've been working on outside of ourselves. We're going to talk a little bit about the changes that we make when we first meet a family into the service, which we sometimes call it intake assessment, but on our team we call it a triage assessment. We're going to talk about, when we do autism assessments and what they might look like within our service and on our team specifically. And then we're going to spend a bigger chunk of time, hopefully, if time allows, if we don't get carried away with ourselves, talking about interventions and how we've changed the way we're working with young people that attend our service with moderate to severe mental health concerns, and how we account for their autism and see their autism when they're in our service, with a specific emphasis on the Being Me group that we developed.
So yeah, so one of the first changes that we made, it started, I suppose, we started by looking outwards and where could we make the changes. So we noticed, I suppose, a gap in some of the literature and resources that we were providing to families and young people attending the service. And we really wanted to be sure that if we were providing young people with information, that it was respectful and helpful and it was what people actually needed. So we wanted to make connections and to learn and to get as much information as we could from the autistic community themselves. So we reached out to As I Am, who I'm sure we're all very familiar with, our national kind of autism charity in Ireland. And what started as kind of linking in and kind of opening up conversation has actually spiraled and led to the creation of 3 resource packs as a joint collaboration between our service and As I Am. So we started developing resource pack on starting your autism journey, and this was something we really wanted to create as we were recognizing the unique kind of position that our service played for a certain cohort of people who were starting their autism journey, like maybe at a later stage, maybe in adolescence, and through a child and adolescent mental health service. So this booklet is available online on the As I Am website. And from this booklet, it led on to the creation of 2 further resource packs. One post-diagnostic resource pack, which is due to be released in the coming weeks. And one final booklet specifically on autism and girls, which is a particular group that we work quite a bit with in our service. So we will hopefully be releasing that early next year. We've only had this booklet for a few months, and we've given it out quite a bit to families, and the feedback has been really, really positive. And what's been positive about this collaboration, as well as for those starting their autism journey, that it's starting with a neuro-affirmative message, from the beginning. And we're really hoping that we can kind of continue this work and collaboration with As I Am or with other communities out there.
Okay, so moving on to the triage assessment or intake assessment, depending on the team that you're working on in our service. As Paula said, sometimes when a young person comes through our service, it's the start of their autism journey. And that is because oftentimes a young person is presenting to our service with moderate to severe mental health concerns, or concerns that aren't moderate to severe, but they're coming in for an assessment to see if they meet that threshold. And what might become a query in the assessment or apparent in the assessment is that there's an underlying autism that has not been diagnosed, or the young person has not been self-identifying as. And in that triage assessment then, or that intake assessment, it might be the first time that parents and the young people have heard the word autism as describing their young person. So having that booklet from As I Am has been really beneficial for us as a service, because when young people and parents are leaving this meeting, it's nice for them to have something to go away with so that they can process that information. And there's excellent signposting in that booklet as well for them to find out more information. And also for us as clinicians to have something to give them that is, you know, accurate and respectful of the autistic community. And we know that that is safe information to be giving or appropriate information to be giving. So we're very grateful that we've had that collaboration and that we have that booklet available to us and across team members as well for them to be giving out at their triage and intake assessments. The other thing that we're trying to do at our intake assessment is trying to break down stigma that's associated with autism. That is there for many different reasons, but which needs addressing. And one of the things that we try to do is right from the get-go to give that neuro-affirmative message. So when we're introducing the idea of autism to a family as a possibility, the language use that we're using is in line with the wishes of the autistic community, or at least we hope so. And we are trying to give a message of strength and positivity and a message of it being a legitimate difference in this world. And to contextualize the young person's mental health concerns if appropriate. So that the young person and their family can understand why this young person might be struggling so much, or might be clashing with the environment so much, or may, you know, be struggling with their identity or finding a reason for why it is they feel the way they do. So at all times, we're quite cognizant that this could be a possibility for this young person. And by naming that in the session, we're hoping that that reduces stigma associated with autism as well, and that they're getting that positive message right from the outset. So we really do place great importance on open communication, neuro-affirmative language, and also there's a huge psychoeducation piece as well within that triage assessment. The diagnostic assessment, I forgot that this was my slide too. I was like, oh, the shock, it's me again. The diagnostic assessment then as well. So just to, I suppose, to clarify the role of CAMHS within this, because there often is a lot of confusion about who does what within the services. Obviously, the remit of CAMHS, as we outlined at the very beginning, is in the supporting young people with moderate to severe mental health concerns. Now, the practice across CAMHS across this country, and indeed across teams within Lucina, is very different. And Team A are piloting a new way of working at the moment. But we mentioned the operational guidance for CAMHS at the very beginning of this meeting, and we as a team are trying as much as possible to abide by the operational guidance of CAMHS that have been laid out by the HSE. So where does that leave us with autism and with autism assessments? We do autism assessments, but we do have a pathway, an autism pathway on our team. And one of the things that I suppose justifies us doing an autism assessment within our service is in the support of young people with moderate to severe mental health concerns. So we see it very much on our team that if somebody is possibly autistic and hasn't been assessed yet, that in and of itself, knowing that about yourself, can be therapeutic and can cause a shift in moderate to severe mental health concerns. And we see the process of being assessed as well as an opportunity for therapy, that assessment can be used as a therapeutic tool. So in order for it to be therapeutic, the young person needs to be aware of it. So we're trying in as much as possible, navigating that with parents, that the young person be involved in as much as possible in the assessment process. So these are some of the changes that we've made when we are assessing autism in the treatment of their mental health. So if a young person, we want them to be involved and we want them to be on board with the assessment. So if a young person says they don't want the assessment, then we need to have a real good think about that. Obviously, we are using quite a neuro-affirmative language when we're introducing the idea. So it actually hasn't come up that a young person has said that they don't want the assessment. But thinking about it now and as a team, if we're reflecting that, we would probably have to have a think about that. We use the autistic voice quite a lot in our assessment as well. So particularly at the beginning stages for psychoeducation, we provide a lot of content that's created by the autistic community, a lot of literature that's created as well by the autistic community, so autistic authors, explaining what autism is and how it might relate to that young person. We try and tailor that in as much as possible to the young person's age, to the stage that they're at in their knowledge of what autism is, and what they might need as well to progress with the assessment in a meaningful way. The components of the assessment as well have slightly shifted. So you know, we do use the DSM-5 for our assessments, and we base them off that, and we continue to use the ADIOR and the Ethos, which are gold standards in autism assessment. But what we try in as much as possible to do is change the language use when we're using those tools to make sure that we are taking a strengths-based perspective, that we are respecting communication difference when we're looking at the communication sections, and as well that we're accounting for the experience of the autistic person. So rather than looking at deficits, we're looking at difference. So we are still using those tools, but we've adapted the way that we are using them. Another component that we're also trialing using on our team is a clinical interview with the young person. And this very much depends on the young person and again, where they're at and stage in their journey. But again, with the aim of including the young person in as much as possible in our assessment process, we want their voice to be heard. And of course, all the literature that's coming out about masking and camouflaging, sometimes the tools that we're using aren't very good at picking that up or aren't factoring that in. So to prioritise the voice of the young person in the assessment, we've started introducing an additional component, which is a sit down with one of the clinicians on the team, and we go through the diagnostic criteria using neuro-affirmative language, and we try and support the young person in articulating their own experience of the world and how they prefer to communicate, what their experience of social relationships has been like in the past and present, how they experience the world from a sensory perspective, you know, what their preferences are with regards to routine, how they use their body to cope and manage large emotions or just to feel pleasure. All of those different things we would be using in the assessment so that we get the young person's voice. So we get in as much as possible what it's like to be them and to understand them as a person. Leading on from that as well, obviously, it would be, I missed not to talk about the report. We've also started to change our reports. And again, these are stages of progression, and we're trialing all these things, and they are very much our team seeing what works and perhaps what doesn't work. And we're constantly seeking feedback from the parents and the young people that attend our service about what has been working, what hasn't. And the report is something that we've recently changed. We're trying to shorten them a little bit so they're not information heavy. And again, we're trying in as much as possible to use that neuro-affirmative language to make sure that we are focusing on the strengths of the young person and using the labels of difference as opposed to deficit. And again, the feedback session is taking all of those qualities and all those values into account as well. So in as much as possible, having the young person present. And the feedback session, because our assessments are now taking a longer amount of time, because we do have these extra components and we are using it as a piece of therapy, by the time we get to the feedback session, we're hoping that the outcome is not surprising to anybody, that it's more of a piece of solidifying some identity, and then we go on to the post-diagnostic support work that we do on our team. But the feedback session is more about bringing all the information together and reflecting on the person, and then collaboratively, talking about autism as an identity piece for that young person and how that fits within the family and their system, and bringing it back then to their mental health needs, and talking about what what this means for the management of their mental health going forward, how this would be a positive for supporting those mental health needs, and looking outwards then from the individual about what in the environment might be contributing to those mental health needs that we can address them to. This is me again, my goodness. I won't talk too much on this. You're probably bored of my voice now at this stage. Just a brief introduction about adapting therapy on our team. So I mentioned there that at the feedback session, we start looking a bit outwards if there's a confirmed diagnosis of autism there, if the young person is autistic. And one of the things that we're becoming increasingly conscious of on our team is that social model of disability. So if a young person is presenting with moderate to severe mental health concerns, we're not just focusing on, or focusing at all on change within the person. Sometimes we're looking more outward as well. So looking at differentials. So if a young person is presenting with what appears to be a depressive episode, considering as a differential autistic burnout or as a contributing factor to that. Similarly, we're very conscious in our interventions as well for other presentations that we are not, in as much as possible, as much as we can avoid do it, teaching children not to be their authentic self. So trying very much to embrace the authentic self and, to support young people in being true to themselves. So how this might have a repercussion for CAMHS, the thing that springs to my mind is our OCD interventions. We do a group called Bossing Back OCD. And you saw from one of the first slides that we presented that the co-occurrence rate of OCD in autism is quite high. And one of the things that, in the treatment and managing of OCD, one of the gold standard interventions or the evidence-based interventions is exposure response prevention. So you would be stopping young people from engaging in compulsive behaviors. So in this context, you can see why it would be very important for a young person to know that they're autistic, and for the facilitators of that group to know that a young person is autistic, because what we don't want to happen is an intervention that's targeting stimming behaviors or self-soothe behaviors that are conducive to that young person and important for that young person to engage in. So that's just one example of how, we are considering the whole person when they're coming into our service, whether they have a pre-existing diagnosis and are here for moderate severe mental health intervention, or we have been the ones that have been done that therapeutic assessment piece, and they're going on for forward intervention as well. So that's just one example, but what we're going to focus on now is the group.
So the Being Me group, this is, as Sonia mentioned and we mentioned earlier, a kind of a post-diagnostic support group that we have been piloting within the service for over a year now. So it's on its 5th or 6th round, and it started initially on our team, and it's now been offered across the 3 teams in Rathgar. It's undergone some adaptations and changes based on feedback from the participants, from the pilot to how we're running it now. The overall aims of the group really was to explore, like in a strengths-based neuro-affirmative way, the autistic identity and experiences. The format of the group, I suppose we always started with an open day to allow the young people and their families to learn a little bit more about the group, its format, its structure, to have a space where you can kind of ask some questions about the group, and an opportunity for young people to make requests about the group, about topics that we could cover, about their communication preferences before attending the group. So the group then itself consisted of 2 components. So we ran a parent group and then a group for the young people. So the parent group has started with 3 1.5 hour sessions, although this is something that we are looking at and hopefully increasing, because I think the feedback from parents is that they would like more than 3 sessions. So the parent group aims to kind of, challenge some of that stigma around autism. We're looking at the history of autism and its portrayal in the media over the years, and we try to challenge that and use a neuro-affirmative approach to break that down. It has provided the parents, of young people attending our service a space to kind of connect with other parents, and we recognize that the parents attending this group, are in a unique situation. They are the parents of a young, recently diagnosed autistic person, but who is also experiencing mental health concerns. So the feedback has been really positive from parents, and while we have only had the 3 sessions, parents themselves have made lots of connections and often shared details and continued on that support themselves. But hopefully we are hoping to maybe be able to add a few more sessions to the parent group going forward. And then the young person group, I'll hand you back over to Sonia to fill you in a bit more on that.
So the young person group is actually where it started. We developed the group and then quickly realized that we needed as well support from parents too in the home, so that there would be systemic change, that it wouldn't just be the young person that would be exposed to some of the ideas and to some of the content that we bring up in the group. I suppose the primary reason for the young person group was we were noticing that after diagnosis, there was very little opportunity for exploration of what that diagnosis means for that young person and how they were connecting to that diagnosis as well. So we have quite a mixed response as well, given the fact that most of the time for our young people, it's a later in life diagnosis. So adapting your identity, especially when it's not coming from yourself, when the idea of being autistic might be coming from a clinician that's meeting with you and your family, incorporating that label and that way of experiencing the world and into your sense of self, can often need some support. And as Paula already mentioned, one of the other primary aims of the group is to reduce stigma. So people come to our service with lots of different backgrounds of knowledge of what autism is, and some of it is dominated by the history of autism and media portrayals of autism. So sometimes, again, integrating that sense of self with regards to autism can be sometimes tricky for a young person, or they just need some space to look at what it means for them. So that was the rationale for the group, for the young people. But we were also quite conscious that we're coming at this group from the stance of clinicians with all good intentions, but sometimes not what the young people need to hear. So what we do in the group is we prioritize the autistic voice. So we're facilitators of the group, but the content is all delivered by the autistic community. So we use TED Talks, we use newspaper articles that are written by autistic people, we use YouTube videos, lots of excerpts from different pieces of literature, whatever we can find and whatever is helpful. And a lot of the time, this content is provided by the young people themselves, and we carry it over into different groups too. And we always seek feedback as well of whether or not it's useful. And the topics of conversation are also driven very much by the young people. So we have a huge range of things that we could talk about and have content prepared, but oftentimes the young people have their own agenda and they have different things that they want to talk about, and we run with that as well. So the group is constantly moving and adapting, and very much differs every time it's run, because the groupings of people are different within it. So the idea is that it is a space to talk about issues that are present within the autistic community and how they relate to yourself. We do spend quite a bit of time talking about language. It's always one the young people are quite keen to talk on. And then the other aim of the group as well is peer connection. So much like the parents often appreciate being linked in with other parents, young people also appreciate being linked in with other young people. So what we tend to see is lovely peer connection being made within these groups that carries on outside the group as well. One thing to note as well is that not only does the content change in the group, but also how we run the group too. So we've had groups that are run completely on Zoom, and within that, what that allows for is differences in social communication to be respected. So we may have people with their cameras on who are very comfortable with unmuting and sharing their opinions and contributing to conversation. And then we may have other people who prefer written communication. And what's lovely about using Zoom, and one of the marvels of new ways of doing therapy, is that we have the chat function. And it allows young people who have that communication preference to be able to contribute in the way that they prefer to. So we tend to favour Zoom over face-to-face. Then we also have people on Zoom who would like to attend, but do not want to contribute, and that's perfectly fine. They might have their camera off and their mic off, and we see that as a legitimate way to participate as well. So being there and listening is better than not being there and listening. So we respect that preference too. There was a cohort that did want face-to-face as well. So we ran our first, as soon as it was allowed pretty much by the clinic, we were the first face-to-face group in our clinic after the pandemic. And that finished a few weeks ago. So we had young people come in twice a week for 3 weeks. And that was lovely as well. And we ran it as a camp once as well, the suggestion of some young people. So during the summer, it was definitely the summer, yeah. We had it run daily as well on Zoom, which was nice too. And that did, foster really good peer connections that continued afterwards, as did the face-to-face one as well. So we're looking at maybe a blended hybrid of all of those components. And we're constantly seeking the feedback of the young people too. And one thing that I will say about this group is that it is my favorite one to run, and people who tend to get involved in it also say the same thing. It's a beautiful group. It's really enjoyable. It's very energizing when you're in that space, and it's just wonderful hearing young people be so passionate about who they are and what they relate to, and it's all centered around autism. So for me, it's a fantastic group to be involved in, and that's all down to the kids that do take part. And does it have any positive impact on mental health? We don't know yet, but the feedback is always really good from it. We get the loveliest of compliments. We had it's not a complete waste of time and it wasn't as bad as what I thought in amongst them, which from those kids is like high praise some of the time. So it is. It seems like it's a mutually loved group, and we do get requests that it continue in very different formats as well. So we're looking into that as well, how we might continue that connection with the young people too.
So going forward, I suppose we recognize that like we are still, learning. This is the very, just the beginning of, our journey and our changes within this service. So we hope to continue to learn and grow. And I think, like Sonia was saying, we are learning so much each time that we run this group. We're able to kind of work with that feedback and make some changes, and hopefully we're making it better and for the young people who are attending. We have started an autism working group within the wider CAMHS service, and we are hoping to standardize actually our kind of autism assessment and post-diagnostic support pathway across all of the teams. We are, I suppose, really eager to learn ourselves and to keep learning. So we are open, to some research and ongoing training. And I think, like Sonia mentioned earlier, if there's people out there watching this, who are keen to collaborate on any way, we'd be really interested in that too.
We really want to do some research on the Being Me group, because all of it has been quite informal feedback, which has kept us going. If the feedback was coming back as a negative, we would have stopped it, but we're finding huge benefit. And so I think that's the next step in our journey is to see, okay, is this worthwhile in a very meaningful way, through I think qualitative methodology, or just to see what the experience of being in the group is like for a young person. And then with regards to training as well, I think one of the things that was mentioned was that we shouldn't be keeping this group just to ourselves. And we have opened up, so this was a Team A group initially, and we've opened up this group to the other teams in our service. But one of the things that we did want to find out after listening to our spiel about it was if other people would be interested in something like that. Like, should we be putting something together for distribution, or should we be sharing this information, the content with other people? And we've put together, I know we've gone over time, so the chair hasn't shouted at us yet, but we've found this really useful quiz survey tool. If you go to slido.com, and it will ask for the ID number. If you just pop CAMHS in there, it will bring you to and you can use it on your phone or anything like that, or whatever device you're on. It will bring you to just this question. And it's just a very brief one. You can tick multiple boxes. So if you could tick whether training is something that you would actually be interested in, and what type of service that you're in, so that we can get an idea. And then we might put together like a business case or something, or might put together some materials for distribution, or something like that. But that's us. Thank you so much for your time and attention. I'm listening to the start of our journey.
Paula and Sonia, thank you so much for that. That was such an interesting presentation, and such a positive way of working. And I love the way that the children and young people are at the centre of everything that you're doing. So thank you for that. And there are some really interesting questions and comments and compliments for your presentation. So thank you very much. Please remember to put in your questions for the CAMHS team, who will be joining us again later for the live panel discussion. And now I'd like to introduce Dr. Juliana Azevedo, clinical psychologist in HSE Primary Care Service. She's been piloting a new neurodiversity-affirmative pathway for the child services in her area for children who need a further autism assessment, and will be giving the final presentation tonight before our question and answer session. Thank you, Juliana.
Thank you very much, Claire. And let me see if I can share my slide here. Well, that was really, really good to hear. Sonia and Paul, very much for the presentation. It is very refreshing. So it's interesting to see how I'm, like you are, in one pole of the services and I'm in the opposite one. So I will be talking about kind of a primary care service or pathway that we are incorporating in our service. So first of all, I would like to thank Davida, Jessica, and all the organizers and participants for all their amazing work putting together these seminars, and say that I feel very honored to be part of it. I also want to echo what everybody has been saying in terms of my journey, or this journey, in terms of the neurodiversity affirmative one, which is really kind of a journey. Like I know I have a lot to learn about and to implement in my work, and I hope to obviously continue that journey. I also would like to thank my colleagues, my principal, Dr. Graham Connor, but as well as especially APs that have been working with me in this journey, which are and they are fabulous. So Connor O'Kelly and Alwyn Money, and also some trainees like Catherine Kinsella, who made this pathway possible. I would like to thank a lot kind of the families that I've met during this time, especially the kids and teens that had given me such an insight about their lives, passions, struggles, and were so open and honest about themselves. So just to give you a context, my presentation will be based on my experience of developing and implementing a pathway, which we are calling developmental clinic in our primary care service. So that is the mission that our mission in CH09, and those are the services that we provide in Grange Gorman Primary Care. That's where I'm based. So we provide consultations, drop-in clinics, developmental clinics, and other interventions. And primary care is really the kind of the first entrance to psychology, if you like. So we work with mild to moderate presentations, and most of our referrals come from GPs, other professionals, but also self-referrals. So this pathway is about that journey in terms of identifying or listening to clients in a different way, but also in relation to my own experience of trying to recognize, value, and incorporate what can be translated as differences into my work. I'm originally from Brazil, so I'm used to be seen as different on a daily basis. But in my view, being a foreigner invites me to be in a very privileged place and allows me to be super curious about other people's experiences, cultures, beliefs, distinct ways of thinking and being in this world. So one of my first jobs as a psychologist was in a disability service working with autistic children. So when I moved to primary care, I thought I had the background needed to identify and refer kids for further assessment. But I will never forget some of my clients in primary care that taught me so much about the importance of being curious and inquisitive. So Dee was a 6-year-old who loved dogs. He also loved to have cereal for breakfast with 1 spoon of chocolate mixed with his milk. He drew dogs before going to bed, and that calmed him down. He didn't line up cars. He didn't have tantrums. He hated to be separated from his mom. At the time, I thought that a parenting group for parents of kids experiencing anxiety would definitely assist his mother to understand and maybe to be better able to deal with his separation anxiety. She did the group. We met again for a couple of sessions, but no matter what we did, his presentation didn't change. One day, his mother mentioned that going to the supermarket with him was very difficult because every time they were near enough to the freeze area, he would get impatient and agitated. So we then referred to assessment of needs, AON, and he was diagnosed with autism. Or story of Jay, who was so creative and imaginative that wrote stories about superpowers. But the reason for referral was daydreaming in school and not being able to concentrate. And like them, I met many. And as you can see from the slide, these are some of the reasons for referrals to primary care. When you read them, different hypotheses come to your mind, but autism might not be one of them. So without proper further investigation, kids and parents, are normally placed on intervention waiting lists in primary care services. Their families wait for a long time to be seen, and the interventions that we provide might work, but more commonly will not work. So I started to realize that me, with my curiosity, which I was so proud of, didn't really capture the needs of those kids and families. In my defense, the reason for referrals fitted really well the understanding and criteria for primary care. But maybe my questions, curiosity, hypothesis were not the correct ones because autism didn't really fit anymore into what I had learned. It was then when I started using our advice clinic, which is a drop-in clinic, to try and understand a bit more about those referrals. So I would ask parents to come to the advice clinic, bring their kids with them, and maybe in that way, I would maybe have a better understanding of the cases. But I realized that suddenly advice clinic appointments were inundated of those referrals, and I felt I needed to do something different. So we started studying and understanding more about autism through YouTube videos, Twitters, books, and learning from our colleagues about their own experiences. I've also learned a lot about autism with Davida, Maeve, Jessica, Tara. And it was like that I was seeing my service fitted and that made sense. So that's when we thought about the pathway. So we created this new pathway in our service in which every single referral was going to be read or viewed from a new lens. But in order to do that, we had to come up with questions that would instigate parents to think about their kids in a very holistic and strength-based way. We put together a questionnaire with strength-based questions drawn from the DSM-5 criteria. So those questions would incorporate kind of all those aspects here, but in a very strength and language, kind of strength language way. So the assistant psychologist would phone parents and ask those questions in a more inquisitive, curious, but very respectful approach. The parents' narratives and stories were discussed on our referral meetings, and some cases were contacted by us after this original discussion and advised to apply for further autism assessment. Other referrals were a bit more unclear, and I felt I needed to meet the child in order to have a better sense of their own experiences. They were invited to one session with me, which was face-to-face or sometimes online, and most of them in the presence of their kids, or sorry, in their parents. And a decision was made after that interaction. So the meetings with the kids and teens, they were focusing on strengths, view of their view of words, interactions, friendship, communication, language style, preferences, physical movements. And with the younger children, we would play with them, letting them conduct the play, explore their imagination, collaboration, and etc. After meeting with the kids and their parents, we contact parents to discuss and what we had observed, or during that particular meeting. And it was more like a conversation, rather than a more diagnostic type of thing. So it was always about kind of my understanding of what I had experienced during the session, but also parents' understanding of their kids and how they were in that particular session with us. So the conversation with parents after that appointment were always very informative, but also sincere and hard. Approaching autism, or the possibility of autism, with parents was difficult due to the fact that the word can be interpreted, or the autism can be interpreted and viewed in a very negative way sometimes. And mind you, sometimes like we were the first ones to name autism, something that might have not been even thought about by those parents. So rephrasing and reframing autism with parents made all the difference. Also showing my own vulnerability in relation to my hypothesis not being correct, and advising them to go for a further assessment. But once we focus on strengths, and once we focus on what kids were doing, I think that discussion and conversation was much more approachable, if you like. We would discuss with parents what were the difficulties they were encountering, and also guide them or provide them with material that we thought would be helpful for their kids at that particular time. I think we also would, and in those materials, those materials would incorporate kind of, again, YouTube videos or things that were kind of in the media, rather than any type of intervention. For all the kids that we've seen, we provided a letter, supporting letter, if further assessment was recommended. So those are some of the things that or some of the ways that we communicated the strengths to parents. So we would talk about kind of, this person is more logical and literal in her thinking. She has a unique sense of humor. She's honest and has a preference to be more direct in her communication. In relation to relationships, she's very caring towards younger children and prefers to play with them over their same age peers. Other things around routine, organizational attention, concentration. So I think our view was to provide them with, alternatives and focusing on strengths rather than medicalizing and using the words difficulties or different. So from the service, that's another piece in terms of sensory processing and special interests, for example. Now, those are some examples that we use. It doesn't mean that we use for all of them. but some of the language that we have been trying to incorporate. From a service perspective, I think when we started this pathway, the vast majority of kids referred to primary care were invited to these developmental clinics. And of those, more than 60% were referred to further autism assessment. Nowadays, this rate is about 50%. From a service perspective, this approach was efficient because it assisted us to deal with and reduce very long waiting lists, as well as the possibility of diagnosing and informing parents and their kids of what was maybe originating the distress or strengths that the kids were presenting with. I think this is when a more neurodiversity affirmative approach can make all the difference, because we focus on strengths, qualities, what kids can do, their preferences, and that can be really transforming to parents. From a personal perspective, this approach is efficient not only because it is strength-based, but because it relates to a person. It respects their singularities and human rights. So that's me. I stop sharing now.
Juliana, thank you. Thank you so much for that. It's lovely to hear about, a lovely, positive, gentle, strengths-based and person-based approach. So now we're going to delve in a little bit deeper into some of the topics that were raised during the presentation, and I'll start with some questions and answers, if that's okay with our panelists. So I'm going to start with our CAMHS team, with Sonia and Paula. And we had really thought-provoking questions for you, and actually a lot of compliments about your presentation and your wonderful service. So that's lovely to hear. One question that's really interesting is there any alternative for a young person or child who can't manage a group session?
Yeah, so the group, the Being Me group, is often just maybe one part of a person's treatment plan. So everybody who attends our service after their initial triage appointment will have like an individual care plan. So if it's raised in that, depending on the young person's needs, that a group setting may not benefit, then we do kind of discuss that as a team. And depending, on the unique kind of needs of each person, there's obviously other kind of different, treatment interventions. We have occupational therapy, psychology, nursing staff. And sometimes we actually do a little bit of individual work to try kind of, work up and support to maybe attending the group down the line.
Okay, thank you for that. That's great. Another question for you, yeah, I think this is an interesting one. How do you find the time for these groups and this process alongside the usual CAMHS work?
There's only so many hours in the day, isn't there? Yeah. Well, firstly, I suppose this is usual CAMHS work. So we are a service that supports young people in their mental health needs, specifically moderate to severe levels. And we very much see this group as part of that. Although we don't have the research to back it up, we very much see that a lot of the reasons why a young person might be attending our group with moderate severe mental health concerns is because they are either struggling with identity, they don't know that they're autistic, they do know that they're autistic and are struggling with that, and the environment is not set up or conducive to them living an authentic autistic life. And we very much see this group as a way of exploring all of that, and a way of supporting young people in understanding their needs and advocating for themselves. And again, with parents as well, like, giving a different framework to think about autism and understanding autism lends itself to advocacy and truer understanding for both parents of the young person and the young person of themselves. So we very much see it as the usual work of CAMHS. It is an intervention for mental health. So it is within our usual work.
Thanks a million for that answer. Another question that's come in, and yeah, it's another interesting one. Sometimes it's difficult for clinicians to be neuroaffirmative if the label of ASD still includes disorder. Do you use this label with a young person, or how do you explain this to a young person in your service?
So yeah, well, we try to model language use, and that's something that we have learned through our our looking outwards and our working with the community. And so we are trying to model the more neuro-affirmative language use, like Sonia mentioned, in our feedback sessions, in our triage appointments, in our reports. So we use the word autism. But I suppose in the Being Me group, we do acknowledge that the word, the term ASD is out there. We're open about that, and we do discuss that in the group, and with both the young person, and the parents.
In fact, we go through all the different labels throughout history. So we look at all the different ways to refer to an autistic person. We look at identity first versus person first language. We talk about all those things. So it's not a big secret or anything like that, because these are labels that these families and these young people are going to come up against. And we talk about the benefits and disadvantages of all these things and the discussions that are happening out there in the autistic community. And like Paula said, we very much model the language on our team. What I will say is that does take a lot of time and a lot of effort. I think it was mentioned in the first night that all of our trainings as clinicians and professionals, I'm hoping it's changed, but for all of us going through training, it very much was ASD. And to switch does take a bit of effort. It doesn't take a long time, but it does take a bit of effort at the very beginning to become consciously aware of it and to consciously change that. And on our team, we have we started this thing that if someone slips up, we name it as well. So we are trying in as much as we can to be that model of change for families, and to have that right from the very beginning when they come to their service, that is the way we talk about autism. So we tend to try and avoid ASD.
Okay, great. Thanks for that. Probably a more closed question here, but the ages of children and young people in the group.
Great question.
That was something actually that we probably should have clarified a bit more in the group. So the Being Me group is for teenagers. So we from 12 onwards, I suppose, because that tends to be the cohort that we see most often within the service. But the parent group is open to parents of younger children.
Okay.
As well. Yeah.
And then just I know there's 3 sessions, but the length of the sessions, Paula and Sonia.
For the young people, so that has varied as well from group to group too, and it's hard to get the magic number. I think it always seems too less though. I think when we finished, we were like, we could have done with a few more. But when we ran it as a camp, it was 5 days in a row. So we ran it as 5 sessions. And then when we were running it 2 sessions a week, we had it as 6 sessions. So we haven't found that magic number yet, but I don't think we ever will. Probably around 6 sessions.
Yeah.
Okay.
So, yeah, sorry, I was just going to say the parent was 3 sessions, which we think we probably need to add more sessions on. But the younger person session was always around kind of 5, 6.
Okay. Paul and Sonia, thank you so much, and thank you for answering those questions just so clearly and concisely. Thank you very, very much. And I'm just going to look in the questions and answers just to see what questions might be there for Juliana. So bear with me, Juliana, here. I remember when seeing Juliana's curiosity in action showed what could be lost by following a checklist too rigidly, and it served an important learning experience. I'm very grateful for that. So that's just a lovely comment, Juliana. So another question for Juliana. Thank you for your presentation. How do you manage the referral on from primary care for children or young people, autistic children and young people, when waiting lists are long? And for this person who's asking the question, this is often a very difficult part of the process.
Yeah, I'm not sure if I fully understood the question, but I tried to answer it. So I think what we are doing is, like, we are primary care, and as primary care, we don't work as a team per se. So we work multidisciplinary. So therefore, psychology is the only kind of, discipline that is there. So in a way, we can't diagnose autism in primary care, not yet, with all those changes. I don't know what is going to happen, but the way that things are at the moment is that kids need a multidisciplinary team to assess them for autism. Therefore, we have to refer those kids to a different service. So what we are trying to do is to avoid and prevent kids that could be autistic to become CAMHS clients or patients in the future. So the early, so the idea is that, and again, I know it's only possible because I was very lucky to have excellent APs and trainees working with me, which shouldn't be the way. But in our service, every referral is screened. So therefore, they might be waiting for 2-3 months, maybe 4, to be seen, and a decision is made. So that's what we can provide. I know that in other services that we are implementing that as well, and the waiting is longer, So I don't know if I've answered the question.
I think you have, Juliana. Thank you so much for that. This is a question to the general panel. Can any of you recommend a TED Talk to help autistic young people to develop a positive autistic identity? And I have my pen at the ready here.
We do use a lot of them in the group. I'd be hesitant to start naming out things, but if you put into a TED Talk autism, the majority tend to be neuro-affirmative. But just to contextualize a little bit, when we do the TED Talks, we discuss around it. So we haven't yet come across a perfect TED Talk.
Okay.
So what we do is we play them and we discuss them, either good or bad. And we look at language use across time as well and things like that. So we'd also be interested to hear of other TED Talks that perfectly explain what it is to be autistic and are neuro-affirmative. But we tend to take our lead from social media quite a lot. So things are shared that have got positive reception from the autistic community. We'll take note of that and we'll play it. We don't have a centralized list though. They tend to be very fluid and moving.
Thanks a million for that. Jessica, if I could direct a question to you, would you have any advice on sensitive language use, I suppose, when talking about or talking to autistic people?
I think there's been pretty good research to suggest that, and from being a member of the autistic community, that we like identity first. So we like autistic person rather than person with autism or on the spectrum. I think when it comes to maybe with parents and stuff, I think parents, I think Sonia might have said something like this, but parents, their language, they first hear the language from professionals. So the language that professional uses can really influence what parents like. So starting off with neurodiversity affirmative language, I think is really good to kind of have that as your pillar is the wrong word. But yeah, autistic. And I think in terms of, maybe I don't think it's necessary to say autism spectrum disorder or either ASD or ASC anymore. I think it just makes a lot more sense to say autism, because it's just a different neurotype. I don't think we really need to include the word disorder or condition at all anymore. It doesn't add anything.
Yes, thanks so much for that, Jessica. And just as a fellow autistic person, I'd really agree with everything you've just said there. So thank you, Jessica. This is a question maybe for the CAMHS team. So how would we support an autistic young person who views their autism in a very negative way?
Yeah, I suppose that's the whole purpose of what we're trying to do. Because if they're viewing it in a very negative way, then it's you know, it's no surprise that they're attending a CAMHS. Because how do you cope with that? How do you see yourself? And that's obviously going to lead to self-esteem concerns. It's going to lead to masking or like a rejection of the authentic self. So, you know, what we try and do in our team is, you know, try and allow space for that young person to talk about that, to listen to other autistic people within the group with the content that we share, to explore that, to learn about different perspectives. And oftentimes the negative perception of a label comes from stigma or comes from a perception of what autism is. So broadening that understanding of autism becomes really important. And hearing at that neuro-affirmative stance and neuro-affirmative perspective is really important. And meeting other autistic people that you can relate to also becomes really important. So on our team, we're trying to facilitate that as much as possible through, for example, those groups.
Okay, thank you so much for that. I think we have, I'm just looking back up through the list of questions, and I think we have covered the main theme of the questions here. Just let me check here as well, just in case. I think we might actually be done slightly ahead of time tonight. Isn't that amazing?
Can I suggest something just on Sonia's last answer?
Yes, of course, Jessica.
That's just that I think it is really positive. Maybe I haven't processed what I'm going to say out loud yet, but I'll try. But just the building self-awareness. I think if somebody struggles with being autistic, it's good to kind of explore it with them, why they think that and why it's more maybe that they might be taking on outside views rather than inside, and also kind of just exploring how it can be a wonderful thing as well. And that's not the point I was going to make it at all, but I'll stop now because I can't remember what I was going to say. Sorry.
Yeah. So I just really like to thank all the panelists for just fabulous contributions tonight. Like, it's been all so informative and thought-provoking. So thank you very much. Thank you to all the attendees for, again, very thought-provoking questions. That is absolutely, you know, they kind of generated a really good discussion there. So thank you very much for that. I just like to remind everyone, sorry, I'm trying to find my notes here and speak at the same time. So I'd just like to remind everyone of the final night, webinar. Just bear with me for a second. So it's going to be on adapting to a neurodiversity-affirmative paradigm in child and adolescent clinical services, and how to apply all of this to autism diagnostic assessments and report writing. So please do visit the PSI events page to register for the event if you haven't already done so. And please remember, if you do require CPD points, to email autism@psychologicalsociety.ie. Thank you so much, everyone, for attending tonight, and thanks again to all our panelists. Good night, everyone. Thank you.